Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by any.
All right. So now talking about NT scan, couple of lines. Perform between 11 to 14. What do you see? You see the translucent space in the nape of the neck of the baby, right? And an increased NT is associated with certain congenital problems like Down syndrome. Okay, association is there. Then PAPA, beta HCG, right? These are between 9 to 13 weeks of gestation. You must have done this. And then there is a combined first trimester screening, which has got a very high sensitivity, 90%. Detection rate is 90% and the false positive is just 5%. I'll be sharing a table towards the end. So here it is, high detection rate and very low false positive rate, around 5%. No, beta, quadruple tries will always come in the second trimester. We'll not talk about quadruple over here. Chorionic villus sampling and amniocentesis, both of them are diagnostic procedures, not screening modalities, so we'll not be talking about them either. This is what the examiner wants to know. All right. If you mention CVS over here, they know in one glance that there was no need, and that also tells you that this person has to be a little more well informed regarding the genetic test, because CVS amniocentesis are the diagnostic test, not the screening modalities. So yeah, screening where you have combined first trimester screening, that means it integrates the NT and the biochemical markers along with maybe the maternal age as well. So that's the combined screening. Again, like I said, very high sensitivity. And like I said, we can always mention cfDNA, that is cell-free DNA, a novel technique. Just mind this table, guys. I'm sorry for just this last minute. I'll just take 2 minutes. Okay, guys. So this is a very important table. Okay. If you just remember a part of it, part of this table as well, I think that's going to really count on your answers. At least you remember the detection rates. Just look at this. The detection rate of cell-free DNA for aneuploidy, specifically for trisomy 21, is so high. It's 99%, right? No. Karyotyping is not screening. Why? Karyotyping is very specific genetic test. It's not a screening test at all. Not at all. Screening, that means a person who's low risk, we're screening them just in case. Screening tests are usually very inexpensive, and we're using it left, right, and center for the general population. Okay, so they have to have certain very important characteristics. First of all, very high sensitivity, so that unnecessarily we don't start having a burden of false positives. That'll be very difficult to tackle. So sensitivity is very important. Number one, they should be inexpensive and they should be very easy for the general population. Better to be a urine test. It's okay if it's a serum or a blood test, and should be very cheap. Karyotyping, no, it's not a screening test. Okay. See, those people who are not very comfortable with genetics, I have a lot of lectures on genetics. I think they're there in my main theory course, and a couple of lectures I've taken only to solve the certain doubts. And everything that I have taken up till now, any lecture that I take, usually I immediately add it to my theory course. Okay, so I have such people who are not giving DNB exam. They just want to be updated with the latest. Okay, and they want somebody to teach them what is coming latest. Okay, and what better platform than DNB to keep abreast with the latest? Plus, it's usually delivered to them in a very user-friendly style. Whatever comes as the latest guidelines, they are somehow taken a lecture on by me, and then it's added to the theory course. So there are so many practicing gynecologists who subscribe to the course only because they want to be abreast with the latest in the market. And I keep trying to do the justice with them as well, because it's my responsibility that if anybody kind of takes my course, they should be able to derive the maximum benefit out of it. So there are students who are not happy with my notes, or a student who's not happy with my answers. I try to improvise them as soon as I get an opportunity so that their purpose is solved. My idea about telling you this is that if you are not very well versed with the genetics, please go ahead and just watch those lectures. Okay, you'll be able to come up with what is the difference between this thing is CMA or FISH, PCR. Okay, when do we do this next generation sequencing NGS? When to do chromosomal microarray? So these things are described in detail as to what these tests are and what do they tell you. moving forward, let's talk about question number 2. They've talked about shoulder dystocia and the management protocol. So first of all, can quickly just tell me what is the etiology of shoulder dystocia? Why would anybody have shoulder dystocia? I think it's very, very obvious. Why would anybody have shoulder dystocia? That means the head is out and the shoulders are stuck. So quickly start writing down. Very good. So the first thing that comes into your mind is what a macrosomic baby of a diabetic mother. Yes, of course, very good. It could be a contracted pelvis. Okay, a contracted pelvis will let the head out but not the shoulders. It's very highly unlikely, but yes, it happens when there is a lot of adiposity around the torso, or the shoulders are very fleshy. It becomes difficult. It gets hinged. You join the Telegram channel, you're already there on the channel. Otherwise, you wouldn't have been able to write down an answer, beta. So, if you're asking for the class, please somebody just put it down in the chat how to, join the chat. Jeetu, if you're there in the class, Akash, anybody who's there, Rishabh, please write down in the chat how to join the video. I think that's what they want to know. All right. Yes. Oh, somebody's written an anencephaly. See, what happens is that anencephaly, the head is hardly, there as a problem. So what you're basically going to have problem with the shoulders only. Yes. Maybe yes, to a certain extent. So I have a couple of, maybe some will fit, maybe some might not fit totally. But here is some etiopathogenesis. Anatomically, you can have, like you said, fetal factors, macrosomia of a diabetic mother. Maternal factors, it's a possibility that you have a contracted pelvis, or the birth canal might have mechanical obstruction. Poor uterine contraction, somehow the head is out but the shoulders are impacted. Anterior shoulder, suppose it gets stuck behind the pubic symphysis, but that's the physiology, that's the pathophysiology. That they also know there's nothing to write in etiopathogenesis. Etiology is nothing, but pathogenesis, yes, it is. So idea is that what happens is pubic symphysis the bone, and if the anterior shoulder gets stuck just behind the pubic symphysis bone, and if you keep giving fundal pressure, it is not going to nudge. It's going to stay there only. And this bone of the shoulder of the baby might get even further impacted by your continuous pushes. So what you have to do is there a drill of shoulder dystocia, and all those steps have to be taken in quick succession. You don't have to waste time. 30 seconds per maneuver. Okay, and there are multiple maneuvers, right? So call for help immediately the moment you realize that there is a problem. Okay, there is a shoulder dystocia. You already knew that this mother is diabetic, or even if the mother was not diabetic, let's say the mother was obese. Sometimes obese mothers have macrosomic babies, and you were anticipating this problem. The anticipation is a very important key, guys. So you were anticipating the problem. You ask the baby, you ask the mother to push. The head is delivered and it's receding back. It's not coming any further because now the shoulders are aligning, but they're not coming down. So call for help and put the patient immediately in the McRoberts position. Yeah, there are a couple of risk factors like we said. These are very important, guys. Maternal diabetes, post-term pregnancy, previous history of instrumental deliveries. They are all very important risk factors for shoulder dystocia. They say previous shoulder dystocia, is a 10 times more responsible for another recurrence of another, episode of shoulder dystocia. So you have to immediately recognize, communicate, call for help, and then start the maneuvers. So first you have the McRoberts maneuver. Anybody can tell me what's McRoberts maneuver? Quickly, guys. I cannot wait. Otherwise, the class is going to be very, very lengthy. Yes, helper. Very good. It's going to be McRoberts maneuver. You'll have an abduction. Okay, abduction, hyperflexion, abduction. You have to put both the legs right onto the chest of the mother and abduct. Just manually, literally have to make space for the baby to come. All right. So it flattens the sacral premonitory and increases the anteroposterior diameter of the pelvis. So that usually, almost 80% of the cases it works. McRoberts. And with that, give a little bit of suprapubic pressure, not the fundal pressure, just to dislodge the anterior shoulder. Then come the secondary maneuvers like the Rubin maneuver, the wood screw maneuver, delivering the posterior arm. All right. And then last, may you have, those very desperate maneuvers like the Zavanelli or Gaskin maneuver. I'll tell you what they are. In fact, you should be knowing it by now because this is just an answer bank. Again, I'm not teaching this topic to you. So basically, call for help. This is straight away from the RCOG GTG. Call for help, like Robert's, very important. Suprapubic pressure. And then you increase the episiotomy, right? Increase the episiotomy. You must have given it by now, obviously, but you increase the episiotomy. Or if you've not given, then at least give. Delivering the posterior arm, and you start with the internal rotation maneuvers. Now, internal rotation maneuvers are these. This is Reuben, in which you are just nudging, your hand is inside the vagina and you're giving a push on the posterior aspect of the anterior arm. Okay, this is the anterior arm, right? You're giving it on the push is given on the posterior aspect of the anterior arm, so it gets lodged from here. Symphysis pubis is here. Then you have Reuben 2 plus wood screw maneuver. So this is wood screw in which you're giving this, definitely this is Reuben 2 you're doing, but you're also you're nudging this backwards. That means you're giving a push on the anterior aspect of the posterior shoulder, right? And then there is something called as reverse wood screw. You don't touch this anterior shoulder. All you're doing is posteriorly, you're giving posterior arm, you're giving posterior nudge so that this flexes here and this goes there. So delivering the posterior arm literally. See? Episiotomy, you deliver the posterior arm, or you start with internal maneuvers. If internal maneuvers are failing, then you call a consultant, obstetrician, anesthetist, and then you put the patient in all four position if it's appropriate, and repeat all these again. Okay, these wood screw maneuver and all that. And then, of course, desperate maneuvers like Zavanelli, clidotomy. These are all destructive measures and very, very desperate methods. I hope nobody gets caught in that